Welcome back to the deep dive. Today, we are tackling a subject that I think everyone thinks they get.
Oh, absolutely. The classic nose job.
Right, people hear rhinoplasty and they think, oh, that's simple, vanity.
Yeah, vanity. Maybe a teenager who wants to look like someone on Instagram or smoothing out a bump they've hated forever. It feels cosmetic.
Simple even. You just go in, shave a little bone off, and you're done. That was definitely my assumption.
Right.
But looking through these medical texts, I mean, you realize pretty quickly that simple is the absolute last word you should use. This is maybe the most complex procedure in all of aesthetic surgery.
It is the quintessential challenge. And the reason isn't just aesthetics. A surgeon performing a rhinoplasty isn't working in inches or even centimeters. They're working in micrometers.
Micrometers, that margin for error is...
It's terrifying.
It really is. I mean, think about it. Unlike a tummy tuck where you can hide a scar, the nose is dead center on the face. It's the architectural anchor.
So if you're off by even a millimeter, everyone sees it. Everyone. The margin for error is, for all practical purposes, zero.
Okay, so the mission for this deep dive is to kind of peel back the skin, metaphorically of course, and look at the engineering underneath. We're going to talk about the architecture of the nose.
Which is way more structural than people think.
Exactly. And the psychology of the patient, which is a total minefield. And we have to get into this huge debate I saw in the notes between open and closed surgery.
Oh, that's a debate that's been raging for decades, and it's not stopping anytime soon.
But before we even get to the scalpel, we have to start where the surgeon starts, which is the mind.
The mind. Because the most dangerous part of a rhinoplasty might not be the surgery itself. It might be the person asking for it.
This was one of the most fascinating parts for me, the Simon warning.
Ah, yes.
Simon.
I love a good acronym, but this one is literally a red flag system for surgeons, isn't it?
It is. It stands for single,
Single.
immature male,
Yep.
obsessive narcissist.
SIMON. Wow, that sounds incredibly specific.
Yeah.
A little harsh, honestly. It is specific, and for a very good reason. The source material points out that a subset of patients suffer from something called body dysmorphic disorder, or BDD.
So they see a flaw that maybe isn't there, or isn't nearly as big as they think.
Exactly. They might look physically normal to you or me in a consultation, but their perception of themselves is distorted. So the surgeon has to play part psychiatrist.
And screen for this stuff.
You have to, because the goal of rhinoplasty is to operate only once. Revision surgeries are exponentially harder. If you operate on someone with BDD who has unrealistic expectations,
They'll never be happy.
never, no matter how technically perfect the surgery is.
And this connects to that other red flag, the one that sounds like a cliche, the magazine cutout.
The movie star patient.
Right. Someone walks in with a picture of a celebrity and says, give me this nose.
And that's a huge problem. You can't just copy and paste a nose onto a different face. The bone structure, the skin thickness, they're all unique to you. A nose that works on one person might look, frankly, ridiculous on another.
It's a sign to just put the scalpel down.
Pretty much.
Okay, so let's say the patient is cleared psychologically. Now we get to the anatomy. And this is where my whole idea that the nose is just skin over bone just got completely demolished.
Yeah, it's so much more than a wrapper. You have to think of the tissue covering the nose as the skin envelope, and the key thing is, this envelope is not uniform at all.
This is the thick, thin, thick pattern.
Exactly. Let's start at the top, right between your eyes. That's the radix.
Okay.
There, the skin is thick, and it's pretty mobile. You can kind of wiggle it around.
I'm doing it right now. Okay, thick and mobile. Got it.
Then you move down to the bridge. The mid-dorsum. That spot is called the rhinion. And here, the skin is incredibly thin.
And that means what?
It means it hides nothing. It is totally unforgiving. If the surgeon leaves even a tiny irregularity in the bone underneath, a little jagged edge, that thin skin will show like a spotlight.
Wow. Okay, and then we get to the tip,
And the skin gets thick again. But it's not just thick. It's stuck down tight and it's sebaceous.
meaning oily.
Yes, full of oil glands. And that really matters for scarring. Sebaceous skin just does not like to heal nicely from external cuts.
Which is why they're so careful about where they make the incisions.
Precisely. The skin between the nostrils, the columella heals beautifully. The tip, not so much.
You know, speaking of the tip and oil glands, I have to bring up this myth bust I saw. We've all seen that caricature of the drinker's nose, right?
Rhinophema.
Yes, the bulbous, red, bumpy nose. But the source says that's not actually from alcohol.
Correct. That is a really common misconception. Rhinophema is actually an overgrowth of those sebaceous glands, usually because of a skin condition called rosacea.
So it's not the bone, it's the soft tissue.
It's all soft tissue getting massive.
Yeah.
So the fix isn't breaking the nose. They actually, and this is wild, they shave the skin down.
They sculpt the skin.
Literally, they sculpt the soft tissue back to a normal shape.
That's amazing. Okay, one more anatomy point before we move on. Blood. I gather the nose bleeds a lot.
Oh, it's incredibly vascular. You've got blood coming from both the internal and external carotid arteries. And there's this one spot on the septum Kieselbach's plexus where 3 different arterial systems all meet up.
Kieselbach's plexus. Sounds intense.
Well, it's actually a hero when it comes to healing. Because the blood supply is so massive, the risk of infection in rhinoplasty is super low. The body just floods the area with everything it needs.
But the downside is
The downside is you can't see what you're doing. If you just went in there, it'd be a bloody mess. Surgeons have to use specific anesthetics that constrict the blood vessels just so they can get a clear view.
okay, so we have the psychology, we have the raw materials, now the design, the architecture. Because like you said, you can't just put any nose on any face, there's math.
There is ancient math. Modern surgeons are still using principles laid down by Leonardo da Vinci 500 years ago.
No way. We're using Renaissance art theory for plastic surgery today.
We absolutely are. Da Vinci described the facial proportions that our eyes just naturally find pleasing.
Yeah.
For instance, the nose should take up exactly the middle third of the face vertically,
Okay,
and the middle fifth horizontally. If it's outside those ratios, it just looks off to us.
and it gets even more specific, right, with angles?
Oh yeah, take the nasolabial angle. That's the angle between your upper lip and the bottom of your nose.
I'll venture it.
For men, the ideal angle is generally about 90 degrees, a perfect right angle.
Okay.
But for women, it's a little more obtuse, somewhere between 95 and 110 degrees. That little bit of upward rotation is often perceived as more feminine.
So a surgeon is basically getting out a protractor to get these angles right?
Metaphorically, yes.
Yeah.
And it's not just rotation, it's projection. How far the nose sticks out from the
Sort
face.
of Pinocchio factor?
Kinda, yeah. There are formulas like the Good method that use the length of the nose to calculate the ideal tip projection. It should be about 0.55 to 0.60 of the nasal length.
It's just geometry.
It is. But it's geometry with a crucial job to do. Because the nose isn't a statue, it's an airway. And that brings us to maybe the most critical structural idea of all. the internal nasal valve.
This part in the reading was terrifying. The idea that if you mess this one thing up, the patient literally can't breathe through their nose anymore.
It's a huge risk. The internal nasal valve is the narrowest part of the whole airway. It's an angle formed between the septum, the wall in the middle, and the upper cartilages. That angle needs to be at least 10 to 15 degrees.
Which sounds tiny.
It is tiny. So imagine a patient comes in asking to get rid of a hump on their bridge. If the surgeon just slices that hump off without reinforcing the structure,
The sides fall in.
the sides collapse inward. The angle drops below 10 degrees, and the patient suddenly feels like they have a permanent clothespin on their nose.
And there's a way to test for this, right? The Cottle test.
Yeah, it's super simple. You just gently pull the patient's cheek skin away from the nose.
And that pulls the valve open.
Exactly. If the patient takes a sudden deep breath and goes, "Oh wow, I can breathe," that's a positive Cotter sign. It tells you their valve is collapsed.
Which connects to those breathe right strips.
It's the exact same principle. A breathe right strip is just an external spreader graft. It's a little spring that pulls that valve open from the outside. In surgery, we often have to put in little cartilage grafts to do that same job permanently from the inside.
Okay, let's get to the main event, the surgery. The great debate, as the source called it. Open versus closed rhinoplasty.
The Ford versus Chevy of the plastic surgery world, it's a huge deal.
So closed, or endonasal, that means all the cuts are inside the nostrils. No external scar.
Correct, and that's the big advantage, obviously. No visible scars, some say less swelling. But the downside is huge. Visibility, you're operating through a keyhole. You have to feel and imagine the anatomy more than you can see it.
Whereas open is where they make that little cut between the nostrils.
The transcolumnar incision, yes. It lets the surgeon lift the entire skin envelope up like the hood of a car. You can see everything, all the cartilage, the bone, the asymmetry, in its natural, undistorted state.
But it leaves a scar.
It does, but when it's done right, it's almost invisible. And here's the trick the source pointed out. That incision is never a straight line.
Why not? A straight line seems like it would be easy.
A straight line scar catches the light and is very easy for the eye to see. So surgeons use a stair-step shape, or maybe an inverted V or a W.
Camouflage.
Perfect camouflage. It breaks up the line so your eye just glides right over it.
So when they lift that hood, they find the scroll, which sounded like something out of a fantasy novel.
It's a great name for a really important mechanical junction. It's just where the upper cartilages connect to the lower tip cartilages. They often curl over each other, like a scroll.
And that's a key support structure,
Huge. It's a major anchor for the tip. If you cut it or weaken it too much, the tip can droop.
which can lead to the polybeak deformity.
Exactly what it sounds like. The area right above the tip stays too high, and the tip itself droops down, creating a profile that looks like a parrot's beak. It's the classic sign of a surgery where structural support was lost.
It just keeps coming back to engineering. You can't just take stuff away.
You have to rebuild. You have to support what's left.
Now, sometimes things get even more complicated. I read that fixing the nose can sometimes involve breaking the jaw.
This is where you have to see the face as one whole unit. It's called orthognathic surgery, where you move the jaws to fix the bite. But the nose sits on top of the maxilla, the upper jaw.
So if you move the foundation, the whole house moves with it.
That's the perfect analogy. You move the jaw forward, the base of the nose moves too, and the tip can rotate up or droop down. Surgeons have to account for that, often placing a little support graft to hold the tip in place.
And what about patients with, say, a cleft lip or palate?
That's a whole other level of reconstructive challenge. In those cases, the actual bony rim of the nose is often missing or sunken on one side. So before you can even think about the nose shape, you have to build a new foundation, often using a piece of rib cartilage.
Rib cartilage, wow.
You need strong building blocks to work with.
There was one other thing in the patient history section, the really awkward questions a surgeon has to ask about nasal sprays.
Aspirin addiction, yes, and also cocaine use,
Why are those two so important?
because both of them cause extreme vasoconstriction. They clamp the blood vessels shut. If you use them chronically, you starve the lining of the septum of oxygen, and the tissue just dies,
Leaving a hole.
leaving a hole right through the middle of the nose, a septal perforation. And trying to do a rhinoplasty with a big hole in your central support beam. Well, it's like trying to build a tent with a snap pole. Everything's unstable.
So let's zoom out. We've talked about the Simon profile, the thick thing, thick skin, Da Vinci's math, collapsing valves, polybeaks.
We've covered a lot of ground.
What I'm taking away from this is that my first thought, just shave down the thumb, was just laughably naive.
It is a game of millimeters, and it's this constant balance. You have the artistic vision from Da Vinci, knowing what looks harmonious, but you also have to be a structural engineer, making sure the valves stay open and the patient can breathe.
So where does that leave the big open versus closed debate?
You know, the source material really sums it up perfectly. The best technique isn't open or closed.
It's whatever works for that surgeon.
Exactly. It's whatever works best in that specific surgeon's hands to get a great result. The patient ultimately doesn't care about the incision. They care that their nose works and looks good on their face.
That makes a lot of sense.
And, you know, if we bring it all the way back to the beginning, to the psychology, the BDD, the search for perfection, it brings up a really interesting question.
Which is,
What is a successful result, really? We spend all this time measuring angles and calculating projections. But maybe the most successful rhinoplasty is the one that no one ever notices.
because it just fits, it's in harmony.
It's in harmony. Your eyes stop looking at the nose, and they start looking at the person's eyes. The perfect nose is, in a way, invisible.
That is a fantastic place to leave it. The goal isn't a great nose, it's a nose that lets the rest of you shine through.
Couldn't have said it better myself.
Thanks for diving deep with us today. Check your airflow, appreciate your cartilage, and we'll see you on the next one.